Welcome to Scrambled, your space for fertility, owning your 30s, and the scramble that makes it all worth it.
All right, welcome back to the podcast, everybody. I am incredibly excited about today's guest, and I feel especially fortunate to have witnessed firsthand the meaningful impact that he has on people's lives. Dr. Robert Setton is a board-certified reproductive endocrinologist and infertility specialist practicing in Brooklyn, New York. His clinical and academic accomplishments are extensive, with numerous published works on topics such as PCOS, frozen embryo transfer, and donor egg transfer. Today, he joins us to share his personal journey to parenthood with his wife, an experience that ultimately led him to pivot from a focus in cardiology to a career in fertility medicine. He'll also lend us his expertise as we unpack one of the most frequently asked and often really confusing topics from our Scrambled listeners, IUIs versus IVF. Dr. Setton, welcome to Scrambled.
Thank you so much for having me. Thank you so much for the introduction. It really is an honor to be here, and I'm excited.
Yeah.
Thanks for joining us. We're excited. I know we've been talking about having you on for a while. So
Yeah, pretty much since the infancy of the podcast, we've always said that we wanted to get you on as a guest. So thank you for joining us.
Pleasure.
So I know she knows a bit more about your story, but what originally made you decide to become a doctor, and then ultimately tell us about your journey to parenthood from there?
I guess the origin of the story of the decision to go into medicine in general really came, I would say, from a lot of different things. An interest in science, sort of a calling that I want to help people. I also was really interested as well in sort of like medicine and spirituality and religion, how these sorts of things interplay. I actually majored in religion and science, and that's like what my major was in religion and in college. So it was sort of like a multifaceted thing, a real interest in the science and the medicine and wanting to help people, but also how that connects with people's spiritual beings as well. I went into medical school then thinking that I'd end up in a field like, say, cardiology. A second was like maybe developmental peds. Those were just the things that had piqued my interest the most. But I had an open mind going into medical school, but was hit by surprise that I really did like my OBGYN, which I did not think just hadn't really thought much about it prior to that.
You were the same,
Yeah,
right? You were like, oh, I like this now.
Yeah, I
Surprise.
originally thought I wanted to become a midwife, and I did a rotation into labor and delivery and actually hated it, and then ended up loving my experience in neurosurge and was a neurosurge nurse for a long time, which I never would have thought I was. But it's funny how you just don't know until you're in it.
Yeah.
You have no idea until you're in it. And all of a sudden, there's some experience you have or some sort of interaction that just sparks you and you follow it. You have to follow your gut with these sorts of things. So, I was in medical school. I was married. My wife and I decided that we wanted to start building a family. After about a year of trying, we weren't successful. And so we went for an evaluation with one of the doctors that had taught one of our classes during med school.
Do you think at that point, like after the year of trying, you would have thought to straight away go down that path? Or do you think it was the fact that you were exposed to medicine and you were kind of thinking like maybe it should have organically happened by this point?
So I would say that on the one hand, yes, I knew like the medical aspect of it. On the other hand, we were in our like mid-20s and young, and we said, well, there's also, I would say that my wife was getting anxious and worried about it and was sort of, we should just go. Again, I was in a bit of a different state. I was also in training and things like that. And I was like, yes, I want to do this, but I didn't feel as much of the well, we have to get going. But when we were approaching a year, it's certainly reasonable to do. And I said, let's do it. Let's go see what's going on. We ended up finding out that she had diminished ovarian reserve, quite severe. Her AMH hormone was undetectable, so less than 0.0016. She had a high FSH, very few follicles on an ultrasound. She was 26 at the time, seeing levels that you see for someone in their like later 40s. You would never ever think, not a single medical issue, regular periods, everything just completely benign and normal. We knew we wanted a big family, but she's one of 4, I'm one of 5. And so we always knew that felt that we wanted to have several kids. We decided to go straight to IVF. The first IVF cycle, we got eggs, but we had 0 fertilized. So that was failure number 1.
At this point, you were still in medical school,
Yes.
correct? You were not in the fertility field yet.
Correct. Still in medical school. And then we did another cycle of IVF. That one only had one egg growing. They recommended not proceeding with a retrieval and converted to an IUI, didn't get pregnant. Next one, we got eggs, we created embryos, but they didn't develop fully. So we didn't have anything to transfer. So we had failed those 3 times. We saw different opinions as well. 2 different providers said, based on everything we're seeing, I think you should just do donor egg. Weren't ready for that. Again, still quite young. And so we kept going. We made it to an embryo transfer, as a fresh embryo transfer, did an implant. We got to cycle number 6, put in 2 day 3 embryos because we're in sort of desperate situation land. And we got pregnant. When I always say the moment I had was when I saw the heartbeat for my oldest son. I said I was such an overwhelming moment after all those, after all that time, after all the disappointment and the up and downs. I said, there's nothing like I've ever experienced like this moment right here, and probably could still say that to this day. I have to bring this to other people. And so I said, that's it. I'm going into this is what I'm going to do for the rest of my life. I'm going to become a fertility specialist.
Can we talk a little bit about the day you just referred to it? You did a day 3 transfer, and for
I was
Pete,
going to
Oh,
say
you
that.
were?
Yeah, I was
'Cause-
going to say, what is day 3? What's
right?
the
Because
difference?
remember how we've talked about
How it has
blastocysts
to
and
get
you've
to
learned about
blastocysts.
that.
Yes.
So
Why?
Yes,
Why?
yes. Okay, so day 3 transfers really have fallen out of favor essentially at the this day and age. There still is some role for it in certain circumstances, with say repetitive failure of blastulation. Essentially, after the egg and sperm fertilize, they develop over the course of 5 days or so, and they go through certain developmental stages. So on day 3 of development, they're at the cleavage stage. Historically, embryo culture wasn't as good as it is nowadays, and embryos would be put on day 2, day 3, etc. Nowadays, we're able to culture the embryos out to the blast stage very well. The advantage of that is that it helps with sort of natural selection, if you will, right? The embryos that are able to make it to the blast stage have the highest potential of resulting in a live birth. Because many embryos, even if they're abnormal, they're not going to, ultimately implant, will make it to day 3. They just won't make it. They just won't fully develop, essentially. So it's sort of like weeding out embryos that may not be making it. Now, it's not necessarily true that what would be a healthy embryo will make it to a blast. And so that's where day 3 transfer still may have a role. But some people, embryos just don't do well in a lab environment. No matter how well you optimize the protocols and sperm, et cetera, everything that you can do, sometimes they just don't blastulate. And so in those scenarios, doing day 3 transfer still has a role.
yeah, I don't know if I've ever seen one in the couple of years that I've worked in fertility, to be honest.
Would you say that, what are they, fresh or live transfers? Fresh transfers
Fresh
are
transfer.
even less common than day 3, or day 3 is less common than fresh?
I would say day 3 is probably even less common.
Wow. Okay.
Yeah, fresh embryo transfers certainly have a role as well. Again, as sort of embryo culture is becoming better and better, we end up with more embryos that are reaching viability. And so then we say, well, we don't need this many embryos, right? If you need a certain number of embryos, obviously, for the short-term goal, the child that you want, and then also obviously for the future as well. But you want to be sort of selecting out the best ones. And so that's why a general strategy ends up being freezing all the embryos, doing PGT, et cetera, just really for a selection process. But to recognize that just because an embryo wasn't PGT, it either is healthy or it's not. It's really just, and there's false positives, it's not a perfect system, but it's one that we generally recommend up front. And if you do well with that, you do well with that. If you don't, then you pivot and use different strategies.
And so for you guys, I mean, it was a long journey for you to even get to that point. You ultimately did 6 rounds of IVF to end up with your son?
Correct. And then
Yeah.
another 7 for my
Right. I was
twins.
going to say, because you don't just have one child, you have quite a few. So can
Wait,
we talk?
sorry, you did 6 rounds, had a child, and then did 7 more rounds and had twins?
Yes.
Okay, so the story is not
The
even
story's
close
not
to
done.
over. Whoa. Okay.
Another 7 cycles.
Wow.
And this was when I was already in training at this point. I was in residency, and we did it in the hospital that I was training at. I would have to run down the hall, do my part of things, and then run back to the labor floor. It was really, really hectic. We were living in hospital housing, and luckily we knew people in the building. But if I was on night shifts and things like that, and she needed a trigger shot, there were people there to help her. But yes, another 7 cycles, and we're doing double day 3 embryo transfers. We did that twice and it didn't work. And then the third time we ended up doing it out of those 7 cycles that we ended up having, we found out that we were pregnant right before we were graduating. We were just trending the labs and we were waiting to have our ultrasound. We were going to the chief resident graduation party that we were having, a little gathering. On the way, I said, you know what, it's like everyone's last shift. Let's go stop by labor and delivery. Maybe we'll do a quick ultrasound. We do a quick ultrasound. I said, we have my little one. We tell him, he goes to one of the triage nurses to hang out for a minute. And I do the ultrasound. And then my wife and I see this clear as day, 2 sacs on the screen staring at us. And our jaws dropped and we were like pale as ghosts. And we had failed multiple embryo transfers. We never in a million years thought that we would be having twins. But that was how we found out that we had twins in a labor and delivery triage on my graduation day of chief resident.
Oh my gosh.
Crazy. Yeah.
So crazy. But I know it's been a long time for you now. I feel so joyous hearing this
I have
because
the chills.
the hardship you went through to get to that moment and then to see 2 sacs. I don't even know how your brain dealt with that information.
Oh, we were zombies the rest of the day.
Is your wife isn't also in medicine, is she?
No, she's not.
Okay, so she just learned what to look for on all these ultrasounds.
She knew.
And
She was professional. She's professional. She and not only that, she ended up I mean, she was she's not zero medical background. You know, she's been through so much. She actually does volunteer work for an organization that where she gets paired up as a mentor for people that are going through fertility treatments, just to help support them and give them advice and things like that. So it's just a little side thing she does.
Yeah. And then hold on, are we done with the kids?
No, we're not done with the kids. So those are
wait, hold on one second. Before we continue with the kids, so the twins you saw were from your last transfer, day 3.
2 day 3 embryos.
2 day 3 embryos, same time, and this time both stuck, so there were twins.
Yes.
Okay.
Yes.
Okay, continue on.
Both boys as well.
Oh, okay.
Now, with fast forward, twins I'm in fellowship now for REI, for reproductive endocrinology and fertility. My twins are baby, they're year and change or so. The older one is, I guess, I don't know, 3 or 4 now. We said, okay, great. We were going for 2. We ended up with 3. We're done. She's on birth control pills, was getting migraines with auras, which is contraindication to birth control pills. So she had to stop them and then called the OB, said, I want to get an IUD. They said, okay, great. We'll get an appointment for you in 5-6 weeks or so. And then she had to change that appointment to an OB appointment because we got pregnant.
And you got pregnant with no medical intervention?
Zero. I mean, we're talking about first being told we need a donor egg by 2 doctors, then 13 cycles of IVF. I remember it was a Saturday morning. It was 5 a.m. My wife woke up from whatever it was. She just had this feeling or something. She wasn't feeling right. She started yelling at me from the bathroom, Robbie, get over here. Look at this. And I get up and I'm like, I can't see anything. I was like, you're crazy. Just go back to sleep. She walked across the street to clinic because I was living in the hospital housing, so we were right across the street. She got blood work done. She's pregnant.
Were you you're crazy?
I thought she was crazy. I said, you're crazy. Yeah. I was like, it's impossible. We both just have religious background, upbringing. So story in the Bible of Sarah laughing when she found out that she was pregnant. So we called my last son Isaac.
Oh, wow. Wait, you have 4 boys.
4 boys. 4
Wow.
boys. Now we're done.
It's funny because, this is exactly why you shouldn't do this, but at the point of having 3 kids and thinking to myself, it took so much to get them with IVF intervention, and I have such a low AMH, I don't even know if I would have thought to go and get an IUD. I would have been like, it's fine, it's never going to happen.
That's what I was thinking. I'm like, why is she going on birth control? There's no way.
Yeah. Well, when you have little twins, you were like, I don't even want a miracle to happen here.
Yeah. I know the thought of a toddler running around, these 2 twins, and then this unexpected pregnancy.
Yeah. And they were only 1, so you had 3 under 2?
So we had 4 under 5. Yeah.
Oh.
Yeah.
Oh my gosh, that is insane.
Yeah.
So that's a crazy story. I guess maybe this is a question for your wife, but you might be able to help a little bit. So You being an IVF doctor and you seeing these women who struggle every single day, and some people try 2 rounds and they give up. Would you say your advice is always like, keep going, do more because of your own personal experience? Or is it, I mean, I guess it's different for everyone, but I mean, your wife is like a hero.
I know.
Yeah.
How did she do
resilience
that
is
many
insane.
times? I mean, I've never
Incredible.
even heard of that.
The way that she had handled it really was, every time that she had disappointment, she would take that day, and that would be sort of like the morning day. She'd take the time, be sad about it, be upset. She would wake up the next morning, I'm not even kidding, and she would just say, it's a new day, I'm ready for the next step. She was driven. She's one of the strongest people I have ever met. When I'm with patients that are having failures, so firstly, I know that even when they're first coming to me, nobody wants to be coming to see me, right? Right. No one wants to be going to the doctor for help having a baby. And we try to make it as pleasant as possible, obviously, and be respectful of that, and try to be as efficient as we can in the process and helping people with their goals. But there's so many times along the road that there can be disappointment. I always try to encourage as much perseverance as possible, because for the vast majority of people, one way or another, we have a way of having success at the end. We feel super confident we can have success, either whether it's with your own, sperm, eggs, etc., or sometimes using donor or whatnot. Our goals are aligned with whatever the patient's desires are. But there's also the emotional aspect of it, psychological, the financial also. These,
Yeah.
I would say, those very often are barriers. We were fortunate in that at the time when I was in training, I had coverage through the department, essentially. If we had to be paying out of pocket for that many, it is literally impossible.
It's not
Um,
possible. Yeah.
it's not possible. I mean, it's nice, and there's insurance coverage has expanded a lot, but
Mhm.
it's not where it needs to be fully yet, obviously. I think that there should be coverage until you have a baby.
So you even touched on the fact that earlier in your journey to becoming parents, I think it was with your first rounds to end up with your first son, there was at one point the discussion of converting over to an IUI from an IVF cycle. I think a lot of people have heard the term IUI,
Right.
but they A,
Don't know
don't
what
know
it
what
is.
it is, and B, don't know the difference between an IUI and IVF. So can you just simplify that for us?
Yes. Okay. So IUI stands for intrauterine insemination. In the uterus, sperm is going in. The idea is that at the time of ovulation, we are getting sperm as close to the egg as we can possibly get. What happens essentially is that you either given medication or a natural cycle is monitored. We wait for ovulation, or we can trigger ovulation to be a bit more precise with the timing. And then essentially we get the sample of sperm. It gets processed in the lab for about an hour to concentrate all the sperm into a very small volume and sort of activate it so we have a nice amount of robust moving sperm. And then it's just really like a fancy pap smear. The sperm goes into a small, tiny little thin catheter, and that goes through the cervix, and the sperm is dropped off into the uterus. So you get a high amount of good quality sperm close to the action when the action's happening, essentially. That's the IUI process. It's a pretty low tech process. Again, sometimes 5 days of pills in the beginning, potentially a one-time trigger shot just to cause the release of the egg, and then just a pap smear essentially after that.
So it doesn't hurt at all. It's not going past where like a pap smear goes, like a swab goes. You're literally just like shooting it in like a solution.
It does go past where a pap smear goes. So there can be like a tiny bit of cramping, but usually very minimal, if anything.
Not like an IUD pain though, or anything like
No,
that.
no, 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 no.
No, no.
No,
Okay.
not at all. Not at all. I would say very often people will say, "Oh, you're done," like anticipating that it'd be a lot worse.
Yeah. And under the vast majority of patients, probably 95%, are fully awake, alert during this kind of procedure.
Absolutely. Yeah,
Yeah.
absolutely. It's done just in the regular office.
Mhm.
Wow. Okay. Well, that seems like, I know it's not, but it seems very promising. Like you're putting it right there, right
Yeah.
together.
So the max that we can hit success rate for this is about 20% per attempt.
Okay. Okay.
And that actually is what baseline natural fertility is. If you're in mid-20s and everything's 100% healthy, chance of getting pregnant is about 20%. The success of it depends on mostly age of the female and also the total motile sperm count of the sperm. So really we use IUI in two main scenarios. One is a mild male factor where there's some compromise to the sperm, so we're trying to help it out, but it's not very severe. And then two would be in the context of unexplained infertility, where all the testing is normal. We're not really sure. Let's try to give some Clomid, get one, 2 or 3 eggs to grow, and then get the sperm closer. Maybe that'll just help overcome whatever subtle issues that there are.
And we've got that question from a few listeners or people that have come on to share their own stories about their journeys to parenthood. They often say, like, we were originally recommended to start with IUI and potentially that wasn't successful, and then they moved into IVF. And so would that sort of be the rationale maybe in that decision making, that there was that unexplained, we thought, why not just try IUI and see what happens, and then you get more quote unquote invasive as you move along?
Correct, correct. The idea is that with IVF comes risk. In medicine, as with anything else, it's always a matter of weighing risk and benefit. The best doctor is one you don't need, but if we need to intervene, we prefer to see if we can get away with a low-tech intervention. It's not something that you do like an unlimited amount of times. Typically, a fair trial, again, depends on the specific parameters, but I would say 3 tries or so is generally when people will then progress. For sure, in unexplained infertility, with mild male factor and maybe not, maybe you have a bit more room with that, up to 6. But beyond that, you're sort of hitting diminishing returns with it.
And misconceptions around IUI, a common one that comes up that I hear of and that we've had listeners ask us about is multis with IUI and even multis with IVF. There is big.
What's a multis?
So
Multiple eggs at once.
resulting in multi-pregnancy. So
Like having twins.
correct.
Yeah.
Yes.
What
Yes.
are the facts behind multis with IUI and multis with IVF?
Yes. So the max you hit for like the max you would hit with multiples for IUI is with Clomid IUI in someone who is young can reach up to 8%. Letrozole is less, it's a less than 5% chance, but it also depends on whether you're doing medication or not. If you're doing a natural cycle IUI, meaning we're just waiting for the natural egg to grow, there's no difference compared to natural conception. It's really more so the Clomid, the ovulation induction or the superovulation caused by the Clomid or letrozole.
Okay, so Clomid and letrozole can cause super ovulation.
Correct, and which is part of the goal. We're trying to get 2-3 eggs to grow to increase the chance.
Can we talk about twins for 1 second? Because I actually just learned this, how twins form. If you're identical, obviously the egg splits. That's like random, but fraternal twins are genetic because of the superovulation, right?
So if you're releasing more than 1 egg at a time, that's how you
Right.
get it. Yes.
Okay, but you have to be doing that to have fraternal twins, and that's like
Correct. So that's the IUI realm. Now with IVF, the historically had very high twin rates because we were always putting in multiple embryos because the embryo culture conditions weren't very good. So it was like, great, you have 4 embryos, just put them all in because maybe one of them is going to stick. The process was really inefficient historically. I mean, still incredible, obviously. I mean, but less efficient than it is now. Nowadays, vast majority of embryos are single embryo transfers. So we're only putting in 1 embryo at a time. That being said, a single embryo can still split into an identical twin, about 1.5%.
but you'll never have fraternal through single embryo IVF. You can't.
Correct.
What would be the reasons? I'm asking because I know someone who, this was probably
Perfect.
5 years ago, so she was probably 25, 26 at the time. They did multiple embryos at one time. She got pregnant with 5 and then ended up keeping 1. I don't know the whole story, but why would you still do multiple embryo transfers?
My heart is like, oh my God. I can't think of a good reason of why that's being done.
I don't know the whole story. I know the story through someone else, but just in general, I guess why multiple at one time? If one's not working, it's like a Hail Mary.
Correct. The scenarios where we put in multiple embryos nowadays are, so firstly, if you have a tested embryo, meaning they do PGT, pre-implantation genetic testing on the embryo, guidelines are that we should put in 1, no matter what your age. If you have an untested embryo that's at the blast stage, it depends on your age. And there's sort of like guidelines for this. If you're under the age of 35, we're putting in 1, or you could put in 2 if you have either poor clinical history, meaning you failed multiple attempts, or you have very poor quality embryos. The embryos get graded A's, B's, C's, etc. Poor quality embryos have lower chance for implantation. And so in a scenario like that, you may be putting in multiple embryos potentially. If you're older, there's a higher likelihood that the embryo is genetically unhealthy. Again, these are untested embryos. And so you can be doing 3, 4, etc. in those sort of contexts. Again, also depends on the grading and their clinical history. So there definitely is a role for this. And the sort of ideal scenario is a single blast PGT tested embryo, but that's not feasible for a lot of people. I mean, it's also one, you may be someone who doesn't make blasts and you have to do cleavage stage, in which case you're putting multiple in. Also, maybe it's not covered by insurance and we don't want to incur the additional costs of this. And, And so we just, we don't test the embryos. And again, that's fine. We're not selecting out embryos. We're just using our best estimations as to how many of them may end up being healthy ones or not.
It's so fascinating. For people listening, like this can feel so overwhelming because the more you get into things, the more the average person who has no idea about these things, who maybe is struggling their fertility, they're listening and they're just going, this is so overwhelming. What is your advice to someone who is maybe experiencing infertility, doesn't know where to start? Like, what's your advice to someone? You've been in the position yourself.
Yes, yes. Seek help. There's no shame in having infertility. Is one thing I want to say, like out loud from the rooftops. Also, infertility is a disease. Nobody chooses to have infertility. Same way some people have asthma because they have dysfunction of their lungs, or they have diabetes because that's a dysfunction of the pancreas. Infertility is dysfunction of the reproductive organs. Find a provider that you feel comfortable with, that's in network, hopefully, that's in a location that's also easy for you, because the process itself involves more appointments than you could ever imagine going to see a doctor for. So you want to go to a place that is recommended either by a friend, your general OBGYN family, a place that you trust, that has a good quality facility, a provider that you trust who will be able to share this information with you, and to sort of joint decision making, because really the decision about which road you're going to end up going down, whether it's IUI, IVF, etc., really depends on so many things: your age, your family building goals, what your testing is looking like. And so it's not a one size fits all. You want to have personalized care, which is something that we always strive to do. But step one is just make an appointment, start the testing, and don't rush. There's always the feeling that you need to, but you have to recognize that even the testing that you're going to be doing takes like a month or so to be doing, because it depends on where you are in the menstrual cycle. It depends on, there's so many we're at the mercy of technology. We're at the mercy of nature. It takes time.
Yeah. I think the thing that I see and you see is that you get these people that come in, and sometimes the journey up until the moment where they seek that care has been so long.
They're like
want to
frantic.
just keep going
Yeah.
and going.
Yes.
It's heartbreaking to watch because there is a lot of waiting, and it's a huge commitment of your time
Right.
and
And
energy and
patience. You need
patience.
Yeah.
patience.
Yeah. Oh my God. It really, really is. There's no greater torture, I think, than waiting than after ovulation, after an embryo transfer, after an IVF cycle, waiting,
Mm.
and waiting
Every
and
step of the
waiting
way.
and waiting.
After you get your eggs retrieved and see if any are even mature. I
Yeah.
mean, that
Every
phone call the next day, you're like, I
It's
can't
like
wait
forever,
24 hours.
Yeah,
forever.
and then you do an embryo transfer, you've got your wait till you're pregnant. Like,
Mm.
it's a constant,
Torture.
constant waiting.
It's torture.
It is a very good practice of patience.
I was going to say, you have to figure out how to keep your body calm because stress will kill it all.
I think fertility warriors make the best parents because they had a crash course in it, and it's incredible the amount that you have to go through when you're going
Yeah.
through this sort of process.
We've said many times on Scrambled, the labor of love that people put into creating a child
Mhm.
using reproductive assistance is just such a show of love to their child. Like, I think it's one of the most amazing things. If you can get through that, then you will always admire the thing that you've created at the end. It's
Mhm.
incredible.
I love that.
Yeah, we say it all the time because unfortunately I've had a patient say to me who came in for an embryo transfer, she said, like, this feels so clinical and not loving. And I literally grabbed her hand. I was like, this is the greatest gift of love to your child. The fact that you've gone through this is more loving and passionate than anything that can happen in the bedroom. Like, this is it.
Yeah.
This is,
Oh, yeah,
yeah.
I love it.
Now, so many people would be listening because you're such an amazing person. You're an amazing provider. I've seen that firsthand. People would be listening and going, I need to see this guy. He's going to help me. Where can people get in touch with you? How can they find you? Yeah, where's Dr.
Yeah.
Robbie Setton?
So Dr. Robert Setton, so I practice at RMA of New York in the Brooklyn office. I'm born and raised in Brooklyn. Maybe you can tell from the accent. I don't know.
I can tell.
So I'm located in RMA Reproductive Medicine Associates in New York's Brooklyn office. We have an office currently in downtown Brooklyn, and we'll be hopefully opening an office soon in Midwood as well. You can find us at rmany.com or 718-532-8700.
Love
Amazing.
it.
I can't
And we
believe I know
will-
by heart.
Oh, yeah. I'll link everything in the show notes to find you. We'll put your Instagram handle in the show notes so people can find you on socials. And thank you. That was fun.
That story was insane. Thank you so much for sharing that.